Let's do it. Okay. All right. Welcome to this month's SCIP, our Stanford Community of Improvement Professionals. This month we have a really exciting, I think, very exciting topic. We've got Chenna Lee and Eliza Ennis here to talk to us about some of the work that they're doing with AI, specifically LLMs and how they integrate with things like Voalte to be able to mine data for improvement teams. So they're going to talk. They've got right now a lot of their work is conceptual. They're in the very beginning of some of this work. So I invited them in so that we could just hear what they're planning to do, listen to their concept, and see if we can engage with them and maybe spur on some ideas of within our improvement community. So with that, I'm going to go ahead and hand it over to Chenna and Eliza. And would you just do a quick introduction about yourselves? What interested you in this concept? What led you to this? And then uh, we'll go ahead and have you jump right into your presentation. After that, we'll have an opportunity for what we often will do is Q&A, and then some time for connecting, some networking a little bit. So we'll have time for everyone to be able to ask questions and engage, uh, and also to share in the chat who they're going to be going for in the game tomorrow, Stanford or Cal. That'll be the other thing. All right, go ahead.
Do you want to go first, Eliza?
Sure, I'm happy to. I'm Eliza Ennis. I'm a fourth year PhD student in health policy, and I've been working for the past couple of years with Lucille Packard, specifically in the NICU and intermediate care nursery on patient flow issues. So we've been thinking about sort of how do we identify key problems, and how do we try to solve those? And we've been tackling it from a bunch of different angles. We're trying to roll out some updates in Epic for some manual tracking, but we're also trying to think about ways in which we can simplify the burden on workforce professionals and all of everything that they're doing with minimizing clicks. Really excited to be working with Chenna and get her angle and how we can integrate AI into all of this. So I would say I'm the maybe more hospital focused person, and Chenna knows all about how to apply the data.
We'll have to figure out together. I'm, I'm Chenna. It's like Jenna with CH. I have CS background. I did CS undergrad elsewhere. I was a software engineer for a while and then came for grad school here doing MSNE. In case people don't know what it is, it's an engineering school still. It's called Management Science and Engineering, which is where David Chenker teaches. And we're both on, well, we both work with him. He's our advisor, and because of that, I've been working with the Children's Hospital in the past year or so as well. Um, for me, it was just a lot of learning overall with all the work that Liza has been doing and how people work. I did a lot of shadowing. And then we had a conversation at some point and realized that there is this part of the data that we just haven't really utilized. And we just always talked about how like we don't have these things, information captured anywhere. And like we're now thinking maybe it is capture, we just haven't looked into it. So that's what happened to this project. And we just went ahead and tried to get way to get the data and was able to actually get the access granted. So thanks to Liza, we did full initial set of data, and at least she was able to look through some of it and see if it makes sense to a human. That's where we are. We can get started with what's going on. I think it might be kind of duplicate information for a lot of things we just talked about. So basically, what we're trying to do is to utilize the Vault text data that people send. It's basically workflow information that people send to each other, to see if we can get both real-time insights and also insights to do PI work. And our guiding principle that David Shanker always emphasizes as well is we can't add more burden to the care providers to do better operation. Well, it's the best if we don't have to. So like, can we, if we're needing some information, flow information in real time, can we do that without asking them to do a sync meeting, another sync meeting, another like entry on another, tool, can we do that without adding more burden like that? Is something that I always try to keep in mind. And as we talked about, Vault messages might be this untapped data source that can help with our guiding principle. Because as most of us probably know in this room, probably more expert than me, we did realize that a lot of hospital staff, not just nurses, it's like nurses, some doctors, some patient placement team, a lot of people in the hospital exchange a lot of text messages daily. I think there are some phone calls involved that Eliza might know a little bit more about. And it's all on Vault. And it's a data set that's owned by the hospital. Like we have freedom to pull it whenever we want to. Um, and this is all, it's not like Epic where it's more like you did the work and then you have to now record it. It's more like they're doing this to get work done together. So it's like to us, it might be the source where all the most real-time data lives. And it's all real. It's not like, oh, I have to think about what I did today. It's like as things are happening. What we think we might be able to learn from the message data, especially along with the new large language model capabilities, which became really good nowadays, as all of us know, is first of all to understand the workflow. So right now, for every PI related project, we spend quite amount of time to understand what's currently going on, how work gets done. And we're hoping that we can get that kind of information about every single workflow eventually in the hospital. And once you do that, then we can figure out where the drift happens. For example, like sometimes we are skipping well, pharmacy education before patient get discharged. For high-risk medication, it's obviously important to do that, but sometimes we just somehow forget to do it. So if that happens, and we'll be able to identify it in real time whenever something is missing from the standard pattern that we usually see. And we'll be able to maybe detect delays. So like if there's one person who is slow at response at a certain time of day, is that person, do we have so much ask for that person that maybe we need to divide the work or like have additional staff members in that unit? All that stuff that centrally the management wants to help with. Can we help with that kind of insights? It's something we're interested in. And over to
Yeah.
Liza.
So for the pilot, we've been looking at the NICU to ICN transfer process just because I have a lot of familiarity with that, but also because it's a sort of well-documented process at this standpoint because we've put in a lot of time into understanding what every individual is doing and what all of the steps involved are. And so we can try to track that and then compare that to what we're seeing in the Vault data. And we can also use that as an example because it involves coordination between many different team members. In some of our tracking, we've seen that it takes 12 different team members coordinating to do one patient transfer. And so that means that we are able to look at messages between all of those different individuals and see to what extent they all need to coordinate, or if some of those messages, could be automated or could be sent forward in a more efficient way. And we've also started working with some of the nurses in the units to be able to refine the process to a more ideal state. And so we could also see as we try to implement that ideal state if there's a transition in how messaging happens over time. So we have this baseline understanding, and then our plan is to use the secure GPT to analyze message data and reconstruct sort of what typical transfer steps look like based on the messages and see whether or not that corresponds with what we've seen in our interviews with nurses and our interviews with other clinicians. And then we will be able to validate to be able to identify if there are any gaps. And I think our current hypothesis is that there are going to be gaps on both sides, that there are going to be gaps where the Volt messages there's not a message that is transmitting a particular piece of information because someone did a phone call or someone did an in-person conversation. But we're also expecting to have there be gaps on what we have on the Epic side or from our interviews that are pieces of the process that we haven't previously captured that we're going to be able to capture using the Volt information and data. So some potential use cases, and this is just based off of, we pulled about 24 hours of data over the weekend because we knew there were a couple of transfer issues during that time. So we wanted to compare, the transfer issues that we had actually heard about with what we actually saw in the Volt data. And what we're able to see is that we can use this data retrospectively. So if we know that there's a particular issue, we can pull the Volt data and be able to see where a potential problem arose, or where a transfer might be delayed. So for example, there was a message over the weekend, still taking care of the delivery, not able to come. And so someone wasn't able to participate in that transfer process because they were doing some other task. And so being able to identify one, if there's like a different person who could step in and be part of that transfer process, or if that person needed to be on that delivery originally, or if that's just a delay that we need to anticipate, but we can build it into our understanding. We also have, from a broader understanding of how the hospital is functioning, we think that this could be really helpful for census management. Um, One of the other cases that we've seen a lot in the neonatal intensive care unit is that clinicians tend to not transfer patients until much later in the day when they start to feel a lot of pressure from the census. So if the census is relatively chill in the morning, people think, okay, we can wait and transfer our patients in the afternoon. But then as soon as patients start coming in, which happens in the midday or mid-afternoon, they start realizing they need to get the patients who are ready to transfer out. And so that creates a lot of staff pressure. And I think trying to understand that in a disaggregated way across the Volt messages could be super helpful. So we've seen messages that saying like, I just got a call about an admit from home. Do we have beds? So this is like a lack of census understanding from people who are operating in the unit, but also an initial feeling of pressure. And so if we're able to use that to try to proactively say, okay, this means that like we really are starting to feel a census load, even though that patient hasn't come in yet and we haven't registered that, we know that in the next couple of hours we're going to start to feel that census pressure. So maybe we move forward on transfers ahead of time. And then also being able to understand more accurately where patients are. So sometimes we'll have a transfer order that's signed, but the patient doesn't transfer at that time. Sometimes they've already transferred, and sometimes they transfer significantly after that time. So if we just use the Epic data, we don't have a great understanding of at what point they actually made that transfer. And so using the Volt data could be helpful for that. And then I think the piece that we will have to figure out a lot more using the AI tools is simplifying workflow by removing repeat conversations. But there's a lot of times where someone messages one person and then messages a separate person in a separate chat, but it's the same information being conveyed over and over. And so trying to actually improve that workflow for people could be a longer term step. And then patient level flow, sort of what are the steps remaining to transfer? And we're already building a tool into Epic that will have that built out for people manually, that they can enter remaining steps. But our hope is that this could make it so that it's not a manual process, but it happens automatically, where if someone sends a message and says that labs are still remaining, then we could also add that into the patient checklist for what needs to happen until they transfer. So this is kind of our overarching vision, and would love to get your feedback and ideas and thoughts, because we're very much still thinking through the process for this, and but ultimately trying to think about how do we validate our accuracy within the using the Volt data and thinking from the pilot perspective of the NICU and ICN transfer, and then how do we also expand that to other types of workflows, think about real-time monitoring, think about how we can integrate this into people's actual workflow. And then in like a longer term future state, how do we proactively manage flow across the entire hospital? And this, I think, fits into a lot of the work that David Schenker and the rest of our group have been doing across the hospital, thinking about the bridge, which I don't know if you guys have talked about it in this group, but thinking about ways in which we can more proactively have real-time data and make real-time decisions across the hospital using that data. So yeah, excited to talk to you all about that. And thanks so much for listening to our presentation.
That was great. Thank you so much. I have a few questions, but I'll just ask one to start, and then I'll see if others. Maybe you could raise your hands, and then we'll just call on people individually. But uh, I love this concept. I'm particularly interested in wondering if one of our biggest barriers of frontline teams and doing frontline work is getting process level data at for units. And I'm looking at Tracy right now, thinking of some of the work we've done with falls with injury, and wondering how to get, sometimes we say, here's the 5 things that a staff member needs to do. And then when we ask them, they say, of course we do that. And then we go and observe and realize, yeah, not so much, And the the thing that we've asked them to do is maybe track that they're doing what they say they're doing, but that's cumbersome. It takes time and energy away from their actual work. It's a big challenge getting that data. And so I'm intrigued by this concept that maybe it won't solve that, but it's at least a way to try to gather some of that information. Is that also something you're looking into? And curious your thoughts with that. And then Tracy, if you want to chime in too, I'd love to hear after.
Yeah, I mean, speaking from a similar experience, when we were initially looking at the transfers, we did 14 observations of like, random transfers that were happening. And of the 14, two of them hit all of our required benchmarks. So, yeah, very, very much understood there. But I think that getting people to track problem is definitely at the core of this. I think the question is going to be like, is the Volt message data enough to cover some of that information? And I think that's one of the benefits of looking at patient flow, because that is where there's tends to be a lot of text conversations happening because there does need to be a lot of coordination. Um, but I think that, sort of an ideal state from a data perspective, maybe not from a people working perspective, but from a data perspective, is that, you do also have the rooms listening in to people and you have the phone calls,
Yeah.
recorded and all of that information, because that would immediately translate into our ability to assess that. But I think that the messages on certain things could be helpful. It just sort of depends on to what extent the process is something that is tracked in messages or not.
Yeah, interesting. Nico, you have a question.
Yeah, I love this idea, and seeing you present it is one of those things where, like, after I hear about it, I was like, oh yeah, duh, like we should totally be doing that, right? I was wondering if, coming out of any of these analyses, like you have, you got any ideas for like, improvements to the Vault system, like recommendations you would give to Vault for like new modules or integrations and things like that. And if you could talk about any good ideas that have come out of that.
Yeah, I mean, I think we definitely need to do something more systematic than what we've done so far. But I think the biggest thing, again, this is from the data side, but I think I've also heard this a lot from the user side, is that it's pretty confusing what all of the different roles are that people put themselves into. And so when we actually parse through the data, it's not always clear which role someone is, because someone can put themselves in for a particular team, but they can also put themselves in, as a resident or as an attending, and those don't always overlap. And so having more, I think, preset roles that people sort of are automatically joining what their real role is for the day, I think could be very helpful from a data perspective. From a use perspective, the biggest things I've heard so far are like inconsistency. Some people, they're especially in OB, really don't use Volt, which means that the nurses have to go back and forth between systems all the time and is also clearly unhelpful from a data perspective. But I think we could do a lot more digging on that. And I don't know, Chenna, if you want to talk a little bit about how we could use the LLMs to help with that.
One thing that comes into my mind immediately after I heard his question was ChatGPT launched this like group chat feature like maybe last week. And it kind of feels like a good use case for, I'm not saying we should use ChatGPT for that, but it's basically a concept of LLM listening to group conversations in real time, and then if there are like answers that it can give. So, for example, if there are repeat questions, like somebody talked about this information already in another chat, and then another person asked the same question, pretty much the same question to another person or same person, Maybe we could just auto answer things is something that comes into mind immediately, but that's gonna be kind of a longer term future, I think. That's a lot more heavy lift than data analysis.
Yeah, that's really interesting.
Also, if there's ideas of things you think we should look for, yeah, let us
Yeah,
know.
yeah, definitely. And for Ryan, like even if you want people to do certain things consistently, maybe we can make an identity on Vault and like give people nudges. Have you done this? I don't know if that's that's a good idea or not, but it might adherence wise it might be better than like hey, remember to like enter these things on XYZ if we need to have people enter anyway. Maybe that's like a better option.
Clippy
Yeah, I
vibes.
mean, one thing I was wondering when you started talking about it, I have no idea, I had no like zero about Volt, but and if it can be like integrated with Epic, I don't know if it could potentially be like linked to encounters, and then,
Yeah.
when like a discharge is initiated, it like automatically generates a group chat with some like basic information about the
Mm,
patient and the discharge at the top for everyone to see. That's just like, pasted up there permanently, and then, kind of tease everyone up for it. I have no idea, like I've never even seen Volt used before, so I have no idea if it supports that. And I know that's like you guys aren't in charge of like the Volt system itself, but um,
Yeah, I think the Epic integration for everything it seems always difficult.
yeah.
But I think even it Volt being able to like sort of predict or us in the background being able to predict and then input to Volt which groups should exist for discharges and for transfers, that would still mean that when someone initiates it, they don't have to manually add every single individual to
Mm,
it.
To Nico's point, Liza and Chinna, I think just being able to mine Volt data to inform, the workflows and processes in Epic, I think would be huge, right? To his point, right? He was talking about, discharges. You're talking about capacity and flow. The discharge delays, a lot of discharge delays, the information is exchanged through Volt. It doesn't quite feed into, Epic, for example, right? Which
right.
is what we track for multidisciplinary rounds. And
Mhm.
so some ways to maybe make that integration or even just, vouch for that integration in some way, I think would be huge. There's a lot of work that's going on in the hospital for discharge orders to actual discharge delays.
Mhm.
I think, what you guys are doing, that might be another great use case for you to test to see if, your process can actually help identify where the delays are in when the orders are written to when an actual discharge actually takes place. So there's so many applications. So thank you so much for bringing this work and continuing to do this work. It's just incredible. And also lovely to hear about David. David and I work very closely on a design thinking workshop. He's an amazing, amazing person, and you guys are lucky to be able to work with him and learn from him. He's amazing.
No, thanks.
Thank you.
Tracy?
Hi, thanks. I'm sorry, I lost connection, so I apologize if you've actually answered this question already while I was out. But I'm kind of curious. So I'm sure, like many of us, oscillate between the optimism and the like fear of all of this as well. But I'm sort of curious about how you're thinking. I love that you're talking about how the text-based conversation is really a lot more close to patient flow or transfer workflow. Like Ryan alluded to the work I'm doing in Falls, but that happens in so many different forums. It would be really hard. But I'm also curious that it's close to the transfer process. What are you like? How are you thinking about validating what you learn there and terms of its actual representation of process? And then sort of like what are sort of the pitfalls that you're anticipating?
Yeah, I mean,
Over reliance on
yeah,
this
Chenna,
information,
you
for
want to start?
example.
Yeah. Yeah.
I think we can start with what we're planning to do with NICU and ICN. At least we have, I guess we trust Eliza's having the work done, a lot of interviews and shadowing, so we can use her knowledge for validation. But I don't yet know how it's gonna scale to the rest of the hospital eventually.
Yeah, and for the NICU and ICN, we're we're also looking at it right now with a lot of case studies, where we actually just pull individual patient files and we track every single movement essentially that we see on the transfer process. And we have a nurse in the ICN and a nurse in the NICU who talk to all the people on those two sides to be able to get their understandings of the process. And then we use all the Epic updates of orders and things like that to validate. So that feels, I think, pretty strong. But then I would say that does show us so far that the big gap is just there's not lots of messages that include specific patient details. So occasionally someone will send a message that has an MRN number or a patient last name. But a lot of times there's sort of an implicit understanding between the two people who are messaging one another which patient that they're talking about. And so one of the struggles that we have is trying to identify which messages actually correspond to which patient transfer. And so a lot of that right now we're doing with timing. So if we know based off of Epic that the transfer happened around a particular time, then we can look at messages that are happening around that time between the types of roles of people that we would expect to be corresponding with that. But that doesn't help us as much when we're thinking about sort of proactive application. And so I think that's definitely one of the things that we're going to have to figure out. Yeah.
As part of the process, like include talking to the folks that were involved in that particular case in real time
Yeah.
or close to real time. Okay.
Yeah, it depends on the sort of day of the week and the transfer. But yeah, it tends to happen like the afternoon or evening after a transfer takes place is that we'll talk to someone.
Yeah, it feels like context problem, that exact thing. It's like a missing context, and where does that live? If that's only in-person verbal communication, then that's gonna be pretty difficult to get. If there is relevant context, like think in places like Epic, now then it becomes question of real-time integration with Epic, which has its own struggles and challenges that I don't know if everybody here knows, but it's not impossible. But it has to go through some difficult conversations with IT people.
The other challenge I think is that there's so much data and a lot of it is not useful.
Yes.
And so trying to both pull and parse through that. And I think right now the biggest challenges is on the pulling side. The way that the framework is set up is that we have to pull it for now through Tableau. Eventually, I think we can pull it directly.
Yeah.
But the Tableau interface is very, very slow. And so it takes a really long time. And so I think thinking about, and that's, sort of as we're testing things, totally fine. But as we think about implementing things, probably figuring out a way to speed up that process. But we do know that it's possible and has been done in
Yeah.
other situations. So
Hey, Michael, I know you had a comment. Would you mind sharing yours?
Sure. This may be all in the same category. So I love this idea of trying to figure out like a vastly more productive way to basically shadow work by capturing the conversations among people who are actually doing the work. So you're seeing those words can represent the real process. That was the thing that immediately jumped out to me. Is that kind of one of the big ideas?
Yes,
Yeah.
definitely. Yeah, shadowing, being the fly on the wall, I think
Yeah.
it's a term somebody used when I talked to them.
So how does it do when if you how general can you be, and does it work if you're trying to, let's say, can you just ask in general about, to, have it lay out how this process is handled, or do you need to sort of narrow the frame so it's working with a population of conversations that are about similar cases for it to be effective in summarizing the process? Because there's like a multitude of processes if you just take a
Yeah.
big bunch of chats for a whole day. So could
Yes.
you talk about like how you're kind of narrowing the analytic denominator or something so you can get it to respond intelligently about the current state process, the real current
Yeah.
state process rather than the alleged one?
Yeah, that's a really good point. I think first problem is like we probably won't be able to just dump entire day worth of conversations into like LLM because of context window problem. And there's a size limit of like how much you can put in. So you're gonna need to do some kind of summarization. One thing that I'll be looking into is to use LLM to like not do the whole thing all at once, but more like categorizing different conversations, different things. So like there might be things that are completely not process related. Like if it's like medication, like what's the dose or something, maybe we're just gonna exclude that. And I think entity recognition is gonna be important, as Eliza pointed out, like how do we know which patient this is about? And once we can do that, then the problem becomes a little easier because then you have list of events that happened for a patient and in the time series, then you'll be able to figure out what the common overlaps are between those patients. And I understand like not everything's gonna be about the same process, but it's gonna still be you're gonna have to get like events that happened for a single patient throughout their duration of stay. I think that can be then you don't have to even like rely on LLM. You can use kind of more traditional process mining techniques to do that.
Interesting. It looks
Um,
like Tracy on the same thread was, I mean, flipping the lens. Like if you're actually shadowing that nurse, does it work just to take the lens of the nurse of the conversations that one nurse is involved in as a different
That's
one than rather than the patient
interesting.
lens, just take the nurse
Yeah,
lens?
Yeah, and I think that's one of the things that is very useful about how the Vault data is structured is that, so what I was going to say is that there's chat IDs and conversation IDs, and what that helps us do is look at, each individual conversation, so a message thread that's set up with people, we can separate that out so we can follow an actual
hmm
conversation, throughout its time. But it also will even sub categorize within a particular chat, and it will say this was a conversation that happened. So there was sort of a set of messages that happened around this time, and then that separately, same chat, but it's a different conversation ID for a conversation that happened later in the day. So that allows us to break up like work processes a little bit. And so that's what Chenna was getting at of we can categorize each of those as a being about something particular. But then I think you're right, Tracy, of like the other angle to go is that for all of these messages, we
yeah,
have who the sender was and who the receiver was. So if we just pull, for one sender, what are all of the different tasks that they're doing? And we can even compare time-wise, are they sending one message 1 minute apart, to a group that's focused on one thing and one that's focused on another thing? And
yeah.
what's that task sharing? So yeah, I think that's a really good idea to look at it through that lens.
Yeah, that sounds interesting. I didn't think about that.
Yeah. And I think another issue, but also interesting piece will be I think it will be so dependent on individuals because some individuals I think use Volt a lot, and it's one of their key ways of managing things. And so the reality of their day might be well captured in that, and then for some people it's not as well captured. And I do think maybe a starting point for us is to try to find those richer examples, even if they're not textbook
Mhm.
for everyone, and use
Yeah.
those to try to capture what does like maximal utilization look like.
So it depends on units too. I think some units might have doctors who are on Volt, and then some units like CVICU doctors don't use, like attendings especially, they don't use Volt.
Yeah.
But yeah, it's gonna be. I don't know if NICU. Do you think NICU doctors use Volt? Okay.
Yeah, mostly. But,
Yeah.
if they're then interfacing with CVICU or something else, they might not.
Yeah.
So,
Yeah. Yeah. Yeah.
yeah.
That last
Does it
comment,
capture context, like whether you're on the phone versus on Volt Messenger?
It does not, I don't think. I mean, maybe there is
I
a
think
field I haven't.
it's gonna be somewhere. That information should be somewhere, I
Yeah,
think.
okay.
I don't
Okay.
know. I don't know if we are pulling it into Tableau,
Yeah,
but
I
from
haven't seen
software
that one yet,
perspective, it
but
has to be somewhere. Yeah.
that would be
I don't know. I'm just
interesting.
thinking about
Yeah.
myself. I hate this kind of texting, but I will type away like
Oh,
super
interesting.
fast,
Okay.
personally.
That's good to know. Yeah.
But I'm not on the at the bedside. I would be moving a lot more and would have to
Yeah.
use
Yeah. It'd be
Volt.
cool if we can like support voice-based interaction or something with Vault.
Mhm.
If that's what's hard. I totally get it if you have to do it like every day, all the time. Your thumbs get tiring. But yeah, if we can do like voice-based stuff, I think that's gonna be a question to Vault team, who might not be here today.
that last comment got me thinking about, I imagine some of the people who would be the best for this this use study is people who are high users. I mean, they're the ones that are really engaged with this. They can switch between things very quickly. I'm curious how representative that is to everyone and whether or not that's going to skew, I guess, how we look at things. I mean, so I guess that would be the benefit to validating our process by watching, because I do imagine that the higher users of Volt are going to probably look different than some of the ones that don't use it, and how that represents the entire ecosystem, of what we're
Yeah.
looking at.
Yeah,
Fascinating.
no, I think it's going to be sort of a careful, which like use the high ones to understand how it can work like best with the data when we have the most clear data. And then when we don't have that clear data, validate to what extent that it aligns with that same process or not. And I think one thing that's interesting with the transfer processes is that technically you can go about them in a bunch of different ways, and the order that you do things can be quite different. But the same, 12 to 40 things need to happen for every patient before they transfer. You need to check, make sure that their medications are transferred to the other unit. You need to make sure that their food is transferred to the other unit. You need to make sure that the clinician in the other unit knows that they exist. And so you may not be using messages for that. You may be calling, you may be talking in person, but those steps are still happening. And so I do wonder to like what extent we're able to use the higher utilization users information to inform where those processes are breaking down might still inform what we don't know about the ones who are not using Volt for those same steps.
Yeah, it should at least get you starting asking questions
Yeah.
and really digging into some things that you might not have been able to see or might not have been brought to light other than looking at things through this lens. I think that's one of the things that's fascinating for me is what it might stimulate in terms of conversations and how we view things.
Yeah.
So that's pretty cool. Michael, you want to share your question?
I was on mute, sorry. Oh, uh, you guys were talking about how like the potential selection bias of the high volt using nurse, maybe that process, their process is different. It's like not a representative sample. Uh, and I wonder if I think you already talked about this, but how might you do your shadowing and then speak back kind of what you see about the current state process or about one situation and see if that's what uh they agree with that. Because we all know the flaws about people describing their work, but
Yeah.
if you see their work and feed it back, often they say, "Oh yeah, that's correct." But have you explored that kind of speak back session?
Yeah, we haven't done it for Volt at all, but we have done two sessions with a bunch of different NICU nurses and a bunch of different labor and delivery nurses on what their process is for transfer. So that's how we sort of got some of our baseline mapping, and we actually had people like hand draw their maps based off of the map. Like we had essentially done a bunch of shadowing, built a map, and then we had them make modifications to that. And so then that became sort of our core understanding of the current framework. And then we've been trying to, work on how do we identify whether or not the messages play into that or not. So yeah, but I think that's a really good point of once we validate.
Any other questions, comments?
I'm wondering if some of the conclusions that you're drawing from analyzing, using AI is sort of um like best practices for how to phrase things, or if you're
Mm.
able to see that like certain phrasings of things like yield faster results or less confusion. And if there's like, potential for, teaching about that.
That's a great idea because that's actually one of the, I think, easiest things to find is people immediately responding, clarify or some more information, please, or what? Yeah, so that's a great idea. I really like that. Yeah.
I did that conversation earlier did catch my attention about when we think about processes from like the step perspective, I feel like we don't really do that. Is there a reason why we don't? Like, do you think, especially from like our nurses in the room, is there can that be something useful to completely flip and just think about a staff's day-to-day experience rather than a patient experience?
I could see a lot of uses for that. There's the wellness angle of burnout, and there's also the if we are looking to optimize workflows or look at trying to engage them in improvement work, and they're already saturated or oversaturated with work. Well, that would make sense why they're not. Why when we try a new effort of improvement or anything, there's a big amount of pushback because they're already at capacity. And so what do we remove to be able to add? Also, maybe what we realize is there's a lot of rework, in their day-to-day functions that we can remove, basic
Mm,
wastes analysis of
I
lean
see.
we can apply. I could see a lot of uses for that could open up capacity to be able to do meaningful improvement work.
Mm.
Well,
That's just
Especially
my
that one doesn't have context problem that we talked about. Maybe something we can look into
it's
quicker.
really it's really interesting. And I think this is what I'm fascinated most about this is that idea of what it's going to open our eyes to. We go down this road and we start looking and seeing, whoa, there's a lot more here than we thought. And maybe we didn't even think of this. Nico mentioned a few things that I think were really good ideas that we could um, look at that I wasn't thinking. So that's one of the things I was hoping we would get out of this session is be able to get some improvers to be able to talk to you and at least stimulate dialogue to be able to say, what about this?
Yeah.
So I think that's been successful. I've really enjoyed this conversation. And what I would like to do is I would love to have you both back. I don't know, maybe we could talk about it after in several months, maybe 6 months from now, to talk maybe sooner. I don't know. I mean, we could discuss that to be able to say, all right, so we had all this conversation. Now, what's it look like now? And take
Hmm.
the journey along with you so that we can learn alongside you and maybe even be pilot sites for the next iteration, as we look to possibly spread and try it out elsewhere. What do you think?
yeah, that would be
Yeah,
great.
that sounds great. And let us know if you guys, anybody gets an idea or like wants to look at certain data with us. We can try to figure that out with you. We only have access to children's side right now. So if
No,
it's
we have
anything in
adult
the,
too. We have adult too.
well, how come you have adult too?
I honestly don't know,
How come
but
you have to,
magically I
okay.
got it. So
Well, we're not, well, if we need to look at it, then we'll have to get the permission again from David,
yeah.
but we can figure that out. So if you guys, anybody has like an application they want to look into with us, since we have students and I guess data as well, let us know. I think
Yeah.
Ryan has our contact information. We can also share here.
You guys mentioned David's name a couple of times. What is his role in this work? What exactly is he helping with? Is he the one that's helping you get the data?
He, I would say this is very much a side project from our main work with
Yeah.
him. But he
Okay.
oversees the, Stanford systems utilization research for Stanford medicine work, and that involves a lot of different students, generally in engineering, but also some people like me in health policy, and doing a lot of different individual projects with areas of the hospital on patient flow. And so some of those other projects are what ultimately inspired us to start working on this project. And so
Yes.
we've talked to him about, the patient flow angle of using Volt data, but we've been running this more individually, but we're hoping that it will integrate in with everything else. So as he continues to work on, the sort of model for the entire hospital system, how do we make sure that these types of ideas are integrated into that?
Wonderful. Because I support, so we on the Stanford healthcare side, we have these management guidance teams that are targeted to look at, improvements for readmissions, for length of
Yeah.
stay, HEI, etc. I'm part of the Tracy, I think it's David Jenka. So I'm part. I thought you said David Jenka.
Shanker.
Shaker. Yeah.
Shanka. Ah, okay. So I think we're talking about two different people.
Okay.
Regardless,
Okay.
regardless, my point is with length of stay MGT, we are the MGT is focused really on improving flow and capacity across the hospital. And I would love to have you guys come and present the work that you're doing because we have these challenges with discharge delays and just really helping alleviate barriers to discharges. And so there might be an opportunity there for you guys to maybe just do a little pilot to help, kind of inform where those barriers, maybe even just a Pareto based on, your findings. So I'll connect with you guys offline. I'm sorry. I thought you were talking about David Jenka. Anyway, I'll
No, but
connect
I
with you
mean,
guys. I'll
I
connect
think
with
this
you.
is also a useful resource for people that there are sort of batches of students every spring that are looking for
Yes.
projects
Yeah,
to work on flow and apply their engineering skills in various parts of the hospital. So if you do have a project that you want to get some students to look at specifically, please reach out to us as well, and I can send the form that goes through David, and then you sort of submit your project idea, and then we'll send you students. So
that's awesome. Thank you.
Yes. Free labor.
yeah.
You got all our attention at that point. Yeah, so
Yeah, yeah.
wonderful. So
Thank you
thank
all.
thank you so very much. We're at time. I'm going to go ahead and say thank you to everyone, and we'll close this session for today. And then for everyone, take a look, keep eyes out on the website as well as through email on what's coming next. Because we won't meet in December. We'll come back in January, whether that's having this topic come back or another one. We'll be in contact with that. So look out for that. Thank you so very much, Eliza and Chenna. This has been wonderful. Really, really appreciated it. And I hope you enjoyed it as much as we did.
Yeah, thank you so much.
It
Great
was
idea.
amazing. Thank you so much.
Take care. Bye bye.
Bye.